Good afternoon, everyone. Let me make my usual and often fruitless appeal to come on down. Uh, you know, remember, in Broadway shows and lectures, the good seats are up front. Churches and synagogues fill up from the back forward. So if anyone would be willing to humor me and move, that would be great. And otherwise, I'll get used to being ignored. We have one bit of logistics to attend to. For those seeking CME credit, there it is. And remember that the CME credit does not work in perpetuity. So get those pencils and papers out and write down the phone number. Take your cell phone out and take a picture and record it, because we will not be repeatedly showing the CME notice this afternoon. And typically the CME office allows this to work for about 72 hours. So I would strongly recommend, if you want your CME credit, get about your business to take care of it today after the lecture. We welcome the Drs. Kupersmith to join us. Let me tell you about them. Dr. Judith Kupersmith has distinguished herself in two careers. The first was as a dancer with the New York City Ballet under the artistic directorship of George Balanchine. Following her career in ballet, she graduated from Hunter College and then New York Medical College. She completed a residency in psychiatry and then joined the faculty at Bellevue NYU Medical Center, where she began her career as an academic psychiatrist. She established a first-of-its-kind specialty clinic, the Performing Arts Center for Health, pioneering a new field of performing arts medicine, an initiative which was subsequently emulated across the United States and internationally. For many years, she collaborated on numerous articles related to the well-being of dancers and other performing artists, including 2 books on the subject. She received many teaching awards, including a mentorship award at Georgetown University, where she was a professor of clinical psychiatry for 20 years. She is proud of her 3 children and 4 grandchildren, who are, of course, all brilliant and talented. Dr. Joel Kupersmith, in a varied and accomplished career, has been a cardiologist, scientist, medical school dean, CEO of a practice plan, and a leader of the extensive and far-ranging VA medical research program. He has written and lectured widely on a variety of health policy, veterans, and research issues. He is now Professor Emeritus of Medicine at Georgetown University Medical Center, and for the past several years was the director, Georgetown University Veterans Initiative, as well as a professor of medicine. Dr. Kupersmith is a graduate of New York Medical College, where he also did his internal medicine residency. Following that, his cardiology fellowship was at the Beth Israel Harvard Medical School until June 2013. Dr. Kupersmith was the Chief Research and Development Officer of the Veterans Health Administration, where he led the VA's medical research program for 8 years, the longest tenure ever. His major initiative was the Million Veterans Program, which is now the world's largest system genomic database and part of the President's Precision Medicine Initiative. The initiative has received widespread praise as a major government, medical, and IT accomplishment. Dr. Kupersmith has over 180 publications with more than 7,350 citations, putting him in the top 5% of medical researchers, and 4 books in his name, most recently publishing on health policy issues, including comparative effectiveness research, genomics, health system issues, veterans issues, and privacy. Dr. Kupersmith's awards include a Medal of Honor and Alumni Association Distinguished Achievement Award from New York Medical College, and an Affirmative Action Award from the University of Louisville. He was elected to the American Society of Clinical Investigation. He's also been on many federal councils and national committees, including the National Institutes of Health Council of the National Center for the Advancement of Translational Science and the Council of Science of the White House Office of Science. His topic for this afternoon is virtual care and the future of medicine. Among my favorite publications is a 25-year-old paper in the Bulletin of the History of Medicine. It is a paper which addresses the history of speeches on the future of medicine. In the paper, the authors analyze, going into the late 18th century, European and North American speeches on the future of medicine. With such a wide geographic range, such a wide range of languages, one would think there would be very little commonality. On the contrary, the authors say, you can reproducibly predict the title of almost any lecture on the future of medicine from the 1760s to the present. They are all, the authors say, a variation of the following blank will transform medicine. In the 1820s, the stethoscope will transform medicine. In the 1840s, anesthesia will transform medicine. In the 1860s, Joseph Lister and antisepsis will transform medicine. By the 1890s, asepsis and William Halsted will transform medicine. In the 1890s, William Conrad Röntgen and the X-ray will transform medicine. Alexis Carrel will transform medicine. The discovery of the double helix will transform medicine, etc. So there are no shortages of how will artificial intelligence, computers, technology transform medicine. The author's second point, which has always resonated with me, is that every new technology or scientific discovery in medicine raises the issue of adapting to change while maintaining fidelity to eternal values. How will we understand beneficence, non-malfeasance, justice, privacy in the face of new technology? Dr. Kupersmith, thank you for joining us, and we look forward to you teaching us about this topic. Thank you.
Thank you very much. Thank you. It's a pleasure to be here. And I'm very glad that Dr. Halperin read through that list of predictions because they were all correct. So I feel like I'm in good company. And only the next 20 years, and we'll see what happens. First thing I want to say is that it's very nice for me to be here in particular, because I have many connections to New York Medical College. As you heard, I graduated here, or there, was not here then. And my wife, Judy, also graduated, as you heard, and went on to a spectacular career. Pardon me? Okay. Okay. All right. I got it. I got it. So as I was about to say, I met my wife while at Metropolitan Hospital while I was a chief resident and she was a medical student. I don't know if that would fly now, but it did then. My son went to New York Medical College. He also became a cardiologist. He met his wife also at Metropolitan Hospital. She was a classmate of his. And my father-in-law, Judy's father, was on the clinical faculty of New York Medical College. So we have many connections over the years, and it's always a pleasure for me to be here. Now, I want to first say what the purpose of this lectureship is. Oops. And in a way, I think that Dr. Halperin actually touched on it. And he said it in a different way, but more in the way that our technology has to comport to the ethical framework in which we practice and understand medicine. But technology is always ahead of policy and ethics, and there are many examples of this. Some of this, you already heard. AI. What do we do about AI? Is it going to control us? How can we control the input to AI, make sure that it's balanced? All kinds of questions. Genetics. Genetics really burst on the scene, and not only with the discovery of the double helix, but about 20 years ago, sequencing became a lot cheaper. And you could sequence, and you could, with a modest grant, you could sequence a large number of genes. This really transformed the field. Most people don't remember that, but that's when we started the Million Veteran Program, because we could do it. It was about 20 years ago. And so we need to, it took years to develop the policies that we now understand genomics, and we now practice or look at genomics. So I would like to shorten that gap, as I think Dr. Halperin implied, between the discovery and the technology and policy and ethics. That's very important in its use, or else it can certainly be misused. CRISPR is another example, by the way. It's how we deal with that is going to be very important. The other thing is that we want to foster new and original policy ideas. Okay, now as to today's topic, virtual care and the future of medicine. I'm almost embarrassed now to say that. I was asked by the National Academy of Engineering last year to help prepare a workshop on what they called remote patient monitoring, but it really dealt just as much with virtual care. And what you're going to see today is a lot of what we discussed in that workshop, and also some of my thoughts about them. First, definitions. Virtual care is the use of technology to deliver healthcare services remotely. It encompasses a variety of digital interactions, wellness services, and others. It's the hospital at home concept. You bring what's in the hospital to the patient's home, all the technology and all that. Related concepts are telehealth and telemedicine. That's a remote doctor's visit, let's say, and many of us did that when during the COVID. And remote patient monitoring, which we do with Holter monitoring, or Apple Watches, and the like technology. The terminology can be inexact and confusing with conflation of virtual care, telehealth, and remote patient monitoring. They get mixed up together. And parts of this discussion will consider all three. Now, virtual care is transformative. The goals are making healthcare more patient-centric, accessible, and sustainable. Sustainable meaning use of less resources. And we won't go into that so much, but patient-centered and accessible. I'm going to repeat that because that's the goal. It might be classified as a disruptive technology. Groundbreaking change has also occurred in bringing care to the patient. Okay, the first efforts in this, as many things in medicine now, started with the pandemic, the COVID pandemic. There was a large increase in telehealth use, and there was a widespread use of virtual care in the hospital at home program. Now, this is a graph showing telehealth. And as you see, there's a big bump early in the use of telehealth, early in the COVID epidemic in 2020, and then it kind of flattened off and to where it is pretty much now. The other thing is the hospital at home pandemic and the hospital at home idea. And there was a need for hospital beds during COVID, and that led to a relaxation of the rules to allow hospital-type care at home. That was the rationale. Now, it turned out that they didn't need as many beds in some areas as they thought. So it was a perceived need, but there was a need overall. So Medicare waivers were given for acute hospital care at home. That is, you could do at home what was done in the hospital. And you didn't have to follow such rules as round-the-clock nursing which is mandated for hospitals, availability of certain equipment, and all that. As of October 2024, 366 hospitals participated in this with 31,000 patients. CMS evaluation was favorable, there was strong support, it was transformative, and in December, Congress allowed it for another 3 months. Big deal. So it will come up again. Over 300 healthcare organizations, including many medical schools, and the Association of American Medical Colleges supported it, and we'll see what happens. There was a lot more to this in getting this done than is on this slide, but it was very complicated. Here's how it's used across the country, the states that use it. And what's interesting to me, if you look up at Montana, Wyoming, Nebraska, these are rural states, and you would expect it to be used a lot more in that circumstance, but it wasn't. Texas, I think, had the most patients in the most hospitals in the program. All right. Now, here's a bunch of conditions in which virtual care or its variants have been employed. And on the left, I'm going to discuss in some greater detail COPD, psychiatric illness, and hypertension and heart disease. Now, on the right are a list of other areas where this has been done: obesity, stroke, sleep apnea, tobacco cessation, epilepsy, diabetes, opioid use disorder treated with buprenorphine. Now, when I brought this up at this meeting, this NAE meeting, I was told that you're crazy. You can't trust people like that. That's the way it was said, actually. And actually, it's been done. It's being done. The VA does it, and it has a huge number of patients in this program, and it works. Postoperative care. That's another area. All right. Chronic obstructive pulmonary disease. Now, this is actually a review of the literature from the Karolinska Institute in Sweden. The two most prominent countries that use virtual care, by the way, are Norway and Australia, for some reason. This is an elderly couple, nice elderly couple you see here. They are being monitored. The data is transmitted through, whoops, shouldn't have done that. It's transmitted through a cell phone and then to these giant data receptacles, essentially. They're giant computers, and you need really large computers for this because you're doing minute-by-minute recording and analysis. There's a huge amount of data that comes in. And then there's an interaction, not only with medical personnel that you see at the bottom, but with informal caregivers, relatives, friends, whoever deals with the patient. And then it goes back and forth across all of this spectrum. Now, the components of virtual care are remote monitoring, transmission of data, digital health platforms, healthcare data storage and sharing, and as I said, huge amounts of data, and online support to patients from providers, caregivers, and others. Now, here's what's monitored in COPD. An ability to speak one full sentence, temperature over 38 degrees, ankle edema, high respiratory rate, high heart rate, low oxygen, cyanosis, use of accessory respiratory muscles, loss of alertness, peak expiratory flow. If all these things cross the threshold, the patient should be hospitalized, or you have to do something. And here's just a recording from one study. You see on the bottom the heart rate, on the top the breathing, breath. And one of the early signs that something is wrong is a loss of variability in the heart rate, which is a sign of increased sympathetic tone, and which will tell you that something either is going wrong or will soon go wrong. So there are many things to look at. Here are the symptoms: change in cough frequency, sputum production, and increased dyspnea at rest. Now, there are biophysical sensors, biochemical sensors, so the biophysical are plethysmography, acoustic mechanical, and so forth to get heart rate, blood pressure, et cetera. There are biochemical for glucose electrolytes, lactic acid. There are the sensor forms, what you use to embed these sensors. The old ones, wristbands, of course, Apple Watch, scales, finger clips. The new ones are chest or arm patches, contact lenses, believe it or not, mouth guards, necklaces, tattoos. You can embed these things. And here's something, the one I sort of took out, pill utilization monitors. You can put something in a pill to determine if the patient has swallowed it or not. And then you can sort of say, naughty, naughty, you didn't swallow your pills. And so it's really all encompassing. You can go a long way. You can tell everything about the patient almost with this. Now, the thresholds, they have to be, you have to decide these. They depend, they're individualized, as I said on the third line there, the fourth, individualized to patients depending on individual risks and responses. And you go from either prediction to prevention is the best thing. If you can detect these things before a major disaster occurs, and they are frequent in COPD, you can really help the patient instead of having to put them in the hospital. Deriving thresholds, there are all kinds of algorithms, and the Bayesian approach is really at the fore. AI, and you need massive data capacities, as I said. Trust platforms is the term of art for that. These are with interoperability, data security, patient-centered control, et cetera. All right, now let's look at this in another way. Here's this woman is also being monitored, patient safety, trust and compliance. That has to be part of this, that you have to be able to trust the patient. Remote patient monitoring, patient data aggregation, data harmonization, multimodal data analysis, clinical decision-making, and then you go back to the patient. Same thing, it's just represented in a different way. And what this emphasizes, at least to me, is it's a patient-centered approach. This is a huge cultural change in medicine, if it happens, if it becomes widespread. We don't know yet. But you go from a hospital-centered to a patient-centered approach. And that's very different. The patient actually plays a role, a much bigger role, always plays a role in their own care, but a much bigger role in their own care, and also develops a much greater understanding of what's going on with their care, of what the physician is doing and why. So this is different. It's one of the many, many transformational things that have happened in medicine over the years. And most of it is directed toward more patient-centered and toward larger organizations, both of which are going to be involved with virtual care. All right, the new psychiatry. This, to me, is one of the most interesting uses of this. And this, my knowledge of this comes with a discussion of one of the former NIMH directors who is a large advocate for this approach to psychiatry. So what this is going to evolve is objectification, I would call it, digital phenotyping of the patient, a naturalistic collection of data for 24 hours. Sensor data, again, objective measurements of mental status, voice and speech biomarkers for sentiment, coherence, and distress, blink rate as a reflection of dopamine status in patients on antipsychotics, measures of therapy, and also measures of therapeutic alliance, which is how they're getting along with their therapist. And then the usual heart rate, blood pressure, oxygen, perspiration, tone of voice, lexical field of written sentences, which is basically does the sentences hang together and are understandable, activity on social networks, and evaluation again, as always, by AI. Now, and here's a sort of a figure of it, patient in the middle, and all these heart rate variability, skin temperature, voice, all these recordings are being made. And also there's active data collection, questionnaires, and so forth. And so you have two levels of information coming into the psychiatrist. The digital interview, see on the bottom there, and the physical connection, the interview. And so this really represents a much greater understanding, or will represent a much greater understanding of the illness of the patient. Now, and this is almost a quote, in a field that currently lacks the equivalent of hemoglobin A1C or blood pressure, virtual assessment could introduce objective measures needed for tracking outcome. A redefinition of mental health and wellness. It's not these other, the COPD is like you take what you're doing in the hospital and you do it at home. There's no difference, really. There will be probably, but there's, the same, you monitor the same things, you do the same medicines and all. This is a difference in the core of psychiatry. It's a movement of psychiatry in a new direction. And so we look at evolution of psychiatry from mental institutions as they were 150 years ago to psychoanalysis. And there's no doubt, in spite of what's been a lot of changes, that Freud was a genius in developing what he did. Biologic psychiatry, which started with the Thorazine, discovery of Thorazine, but really grew in the 1980s, I think, and overtook psychiatry. And then this, objectification, data-driven psychiatry, and we'll see how this develops. It's just really beginning, but I think it's a most interesting use of these techniques. All right, monitoring. Here's a Holter monitor, which was designed, as you might suspect, by somebody named Holter in the 1960s. The original model weighed 85 pounds. It was kind of a stress test. I don't know, they look like brother and sister to me, but here he's getting his monitor. He doesn't look like he likes it very much. And this is why it's done, because let's say for blood pressure, you take one reading and it doesn't tell you much. White coat hypertension, patient's nervous in the doctor's office, blood pressure is higher. This shows the variability in a group of patients. All of us tend to have variability, some greater than others, in blood pressure. So you need to know at least something about this to treat the patient appropriately. Because if all that happens is the blood pressure goes up to 140 over 85 when he visits his doctor, but it's okay the rest of the day, that's very different than having true hypertension. All right, and here's just some of the leads that are used, and you see the watch, of course, and something you hold in your hand, and leads that are put on the chest to implantable monitors. And you do the same sort of thing. You go through computers, you go through the hospital, and then you see, what has to be done with the patient. There's good money in this, apparently. This is a prediction and actual amounts from a company that looks at business models in medicine, and $2.6 billion market in this, cardiac monitors, last year. That's in the US. Worldwide, 9.3 billion. So this is going to grow, I guarantee it, and that's what they're predicting. Okay, so there's three things. COPD, where you get this all-encompassing monitoring of a patient, just the whole life is all their biologic, whatever biologic we can measure, we measure in that instance. Psychiatry, where certain things are measured, really change the field, and then hypertension, where you're just looking to see, is the blood pressure you're recording accurate? That's kind of what you're doing, or to look for arrhythmias. All right, now the VA has been a major user of this. And the reason is it's a system. This works well in a system because you can realize the economic gains from it. And there are 171 VA medical centers and over 1,000 outpatient sites. A huge system, 9 million patients, as shown here. Very suitable for telehealth. And it was started while I was there in 2003. And in last year, 2023 rather, 2.4 million veterans used the program out of the 9 million patients. That's 25%, and there were 11.6 million episodes that were recorded. One of the interesting and I think very useful things they do is they have a constant recording of foot temperature and in diabetics. 25% of VHA enrollees are diabetic, and amputation is very common. So this is a real preventative. This could have a major impact in diabetes. I think it has. And it's kind of a bring your own technology party. You see here the patient's at home and has all this equipment, and the doctors or the provider is at home also with equipment. So both of you can be at home, the patient and the doctor. I don't know if that will fly still, but at least as of a few weeks ago. You see the telehealth program grew with COVID. And this is one of the reasons that this is so important to treat patients at home and for patients to be able to interact with their doctors in new ways at home, because there are so many disabled people that the VA takes care of. That's what they're there for. amputees, individuals who are blind. They have a hard time getting to the hospital. I'm on one of the boards of the Paralyzed Veterans of America, and we've discussed this. And I can tell you that and most of the other members of the board are disabled individuals. I can tell you that this is tremendously appreciated by disabled people. I mean, you can imagine if you need, you know, a van and all the wheelchair and what it takes to get to the hospital to see the doctor for 25 minutes. So this is a real boon, and obviously blind, and so many things can be done this way. And I think it's made a big difference. All right, some of the policy concerns. The economic, digital inequality requires being able to be online, and not everybody can do that. Rural use and care of the elderly and the new family. There are more issues, but I'll just focus on those. First, the economics. Now, Medicare allowed this hospital at home program, but it's still difficult to get Medicare reimbursement. It requires 16 of 30 days at least outpatient care, and there are other things about it. And the reason is it's another cost. In Medicare, you know, you read, I used to go to the CMS economist used to give a little talk once a year on how Medicare is doing economically. And it was always going to end in 7 or 8 years. I can't remember when they even gave a different number. And now it's the same number. It's going to run out of money in 7 to 8 years. Well, it is a big problem. I don't mean to minimize it. But, and so they're always worried about taking on a new healthcare cost, even if it might save money. It might not. And it saves money in systems. And with our form of reimbursement, it's more difficult. It's not necessarily a system. Okay, the other thing is, just think of this. Healthcare is 17.6% of the gross national product. A total of it's a $48 trillion economy. $4.8 trillion economy out of the 27 trillion gross national product of the US. The movement of care outside of the hospital will have substantial economic impact. It'll change occupations. The occupations you see now in the hospitals will change. There will be less people working in the hospitals if this catches on. That will affect not only the hospital, it'll affect the restaurant across the street from the hospital. It'll affect the barber shop down the street from the hospital. It'll affect the people who make uniforms. They'll have to make less uniforms. It'll affect the people who wash the uniforms. They'll wash less uniforms. The restaurants across the street from where they are will be affected. So these kind of, as it's called, externalities, if this catches on again, are going to have a major effect. And I think that there's a general economic impact of this that could come, and it makes people wary. Okay, digital inequality. This is a study on home broadband by Pew. It's a survey, essentially, and you see smartphone use beginning in 2000 is nearly zero, and then home broadband, which grew tremendously after 2011. But it's not equal. It's not equivalent. You see here, just look at the second group bar graphs. Home broadband, 80%, and then this is white, black, and Hispanic. And you say 80% in whites, 71% in blacks, 65% in Hispanics. It's a big disparity in this. And that makes this difficult, makes a lot of things difficult. And as you see, I showed this graph before. Overall, in Medicare, the use of the telehealth service, and the top line here is Caucasians, and the middle are African Americans, and the lowest line is Hispanics. So it showed and how they used these functions and services, and that's important. So there are ethnic and economic disparities in broadband access, and this will be an issue. Rural issues. That's one of the rural issues also, less access. It's a fragile health, but here's the overall picture. It's a fragile healthcare system in rural areas. There's a closing of hospitals for economic reasons. They just can't afford to stay open. And when I was in Louisville, I was the chief of cardiology there. We dealt with this. We dealt with these rural hospitals years ago. And at that time, there were some that were closing. So it's a logical place for virtual care to replace hospitals. You can do this from a hospital, somewhere else. Well, doesn't doesn't work out as well as you might think. And I discussed this in my session at this conference with some of the people, investors actually. And they like this as an idea, but there's a lot of problems, many problems in rural areas. There's a digital divide there, and there's a decreased technical backup, and there just isn't enough money to do this, as well as hospitals. And you see the digital divide, home broadband, just look at the curve on the left, you see less in rural than in suburban or urban areas. Not much less, but it's less. So I think this is a very good thing for rural areas, could work, but there are a lot of problems. Families in the care of the elderly. Traditionally, there have been 7 caregivers for each senior citizen. Seems like a large number to me, but I looked this up and that's all I could find. So there's, between relatives, people they hire, spouses, of course, and maybe even parents. So this is changing. Family members live further away and there are less children. Can virtual care replace families in caregiving? I'm not so sure about that, but people are talking about it. All right, so how do we evaluate virtual care? Just start from the beginning. What are the goals? What are we looking for? It is said to be this is the same as I said earlier, a transformative approach whose goals are making healthcare more patient-centered, accessible, and sustainable. So just looking at the patient-centered and accessible, immediate and specific goals, improve patient and family experiences, how they like it, access to care, cost, and outcome. Improved or equivalent outcome, improved or equivalent cost. Okay, so here's some studies. I'll just go through some quickly. This was a study from that hospital at home program that Congress passed. And they made some comparisons, and I just put this up because to be wary, always, of who the comparisons are made with. In this case, they were made among, it was thought, patients who are not comparable. But there was a positive patient and caregiver experience. That was clearly true. Here's an interesting use in sleep apnea, and I'll just read this. Virtual care via telephone or video consultations and telemonitoring was as effective as in-person consultations in improving sleepiness treated by CPAP without increased cost. And then this is a study of small cell lung cancer, increased patient, caregiver, and caregiver satisfaction with care and mood, decreased need for caregivers. So if you have a patient who has to be brought to the hospital or to his doctor or her doctor for an appointment, if you have this function and the patient doesn't have to go to some other location, you don't need as much care. It's a caregiver who brings them there usually, or her. So this is an important aspect. All right. And then this was a study on CHF or COPD, pneumonia, cellulitis. Again, increased satisfaction, patient and family satisfaction, increased comfort and convenience. So, start again. Virtual care is transformative, healthcare more patient-centered, accessible, and sustainable. Patient-centered and successful. Studies show increased patient and family satisfaction. That's, I think, rings through. Increase access to care, certainly. Positive or equivalent studies on outcomes, positive or equivalent studies on cost. But studies have been mainly observational. Now we have to think of these last two. Is it enough if families are happy, the patient is happy, the patient is more involved in their own care, it works out nicely, but it's just equivalent results on outcome. It can't be worse. Equivalent results on outcome, equivalent results on cost. Is that enough? I think it will have a positive effect on costs and outcomes. I certainly think that's going to be true. We'll see what more studies and, better randomized and studies show. All right, the future. There are many positives to virtual care, telehealth, and remote patient monitoring. High degree of patient, family, caregiver, and physician satisfaction. Increased quality of life. Favorable or equivalent studies regarding outcomes and cost. The impediments I mentioned, the economic issues, the large computing power, lack of equity in technology, need for more studies of value and effectiveness, and the comfort of physicians. Again, This is making care patient-centered rather than healthcare centered, let's say, healthcare system rather centered. That's a difference. That's been happening. That's been moving in that direction for years and years, 20 years, maybe 30 years. We've been moving in that direction, slowly or quickly. Or as I think Ernest Hemingway said, slowly and then quickly. It's because things just click together after a while. And so, you know, the comfort of physicians is while they like it, while we all like it, we are the physicians mostly, what's going to happen in the future? How will physicians feel about this? There's a little bit of loss of control, more than a little bit in some cases. All right, so this is the final. Can deliver virtual care in the current healthcare structure and with the current technology. But there will be technological improvements, further developments in AI. Just read the newspaper day before yesterday. This new development in a DeepSync, I think it's called, major development in AI, making it much more economical to use, actually. That's part of it. Increased computing power, certainly. Here's one, imaging at home. When we can do imaging at home, this technique will grow tremendously. Someday we'll be able to use it. There are attempts at development. Drift to more comprehensive virtual approaches as there is support and as impediments are resolved. That's probably going to happen. How quickly, how slowly, we don't know. And more patient-centered approach to healthcare. That is clearly a part of this. And it's a change, it's a part a cultural change, and in part a scientific change, and a care change. And I think that will happen. Thank you very much. I don't know if we want to, is there time for questions, or if you wish, that would be fine. I don't know if I can answer them, but.
Have people both in the auditorium and online. So I'll need people, if you have a question, to use the microphone so we're sure that the people online can hear. Michael, do we have anything that's come in on your box yet? Dr. Kupersmith, while people are thinking about their question, I was simply stunned by the BYOT acronym for the VA. When I was the dean of the University of Louisville, we made a pitch to the VA for telemedicine for stroke care in rural Kentucky. Minutes saved are brains saved. We're going to get the patient to clot busters or a procedure more quickly by the use of this telemedicine technology. During the demonstration, the machine broke. And remotely, the company fixed it sitting in California while we were in Louisville. The VA people stood up and said, out of the question. We will not have anybody enter the VA computer system even to repair things. That would be a breach of our VA firewall. Are you seriously telling us the VA has now gotten to bring your own technology?
Well, that's my acronym for it. It's bring your own technology. It's the VA people who can use this technology at home. They're still very strict, at least, and certainly I can speak, well, I still have a VA appointment and I deal with the VA. I work there a little bit. They are very strict about their firewall, though. That's an absolute thing for them. And it's part of government security. I mean, now, you can work at home. I have a VA account on email account, and I can access that from home, and so can all VA people. So you can do things at home, but within a firewall and so forth. But their attitude toward this home thing has changed dramatically, and since actually it was through the efforts of. He's actually a neurosurgeon from England who started this program in 2003 and just pushed it for years and years, and it took hold finally.
I honestly didn't think you could use the verbs change and VA in the same sentence. So let's,
Well, that's another discussion.
let's, let's see what we've got coming in here on the chat box for you, Dr. Kupersmith.
Oh, okay.
It's,
How do you think the current, should I read some of these or?
I'll read it for us here.
Okay.
How do you think the current cost-cutting drive of the current administration will affect virtual healthcare delivery? Things change every 4 years. How will this affect virtual medicine? You're among friends. Feel free to speak freely about this one. How do you think the current administration will affect?
I have no idea. I don't know how they'll address this. I don't know. Doesn't seem to be anything that's been discussed very much on that in that sphere. So I'm not sure how much of a change there's going to be. And again, it depends. So far, depends who's put in the healthcare positions. Depends on many things. So I don't I can't answer that. I don't know. I would hope that they would be supportive, but that's all I can say.
We can alternate between online and the audience. A question in the audience here? I can pass the microphone to anyone. Uh, do you have any advice for what medical students, future physicians can do in order to enhance the possibility of adaptation of virtual care in more systems?
All I can say is that they should familiarize themselves with this. I think this is coming. Whether how big it's going, how large it's going to be, how much of a proportion of a medical practice it's going to be in their lifetime, we can't predict, because we can't predict technology. I mean, as I said, if you can do imaging at home, that will revolutionize medicine, in my opinion, and so, or revolutionize this aspect of medicine, let's say. And so that this come quicker, or otherwise, I don't know, we don't know. But I certainly think it's going to be part of medicine of the future. And I think you should understand it. That's the advice I would give.
From the Dean of the School of Health Sciences and Practice, great presentation. Assess the risk of environmental exposures in the patient's homes. They walk around the home with a smartphone in hand to show us the mold, peeling paint, etc., that they're concerned about.
Well, that wasn't a question, but it is true that it's a big issue, environmental exposure. Well, of course, a lot of the Gulf War illness, there were and this is when I was in the VA, is what was it due to? Was it due to some of the insecticides that were given? A lot of discussion about that. And as it turned out, the availability of recompense or benefits for it doesn't depend on the cause, it depends on the result. So that's in general how that works.
Let's combine the top and the third question. One person writes, are medical schools incorporating telehealth education in the curriculum, if not done already? What key areas should be taught and prioritized? And another person writes, I have found hand-holding and touch very important with difficult discussions. How do you value touching in the art of medicine and what virtual care does away with it? And Dr. Kupersmith, when I read these questions, I'm reminded how many hundreds of hours did many of us spend on penmanship in school, right? Writing in cursive penmanship. That's all gone, right? As people are lucky if they can sign their name, much less worry about cursive because of word processing. So will the stethoscope or percussion, will an ophthalmoscope and an otoscope become interesting historical items in this world?
I'm afraid I have to answer that. Yes, someday that will happen. Just as the stethoscope came on, as you described, changed medicine, it can, be replaced. And I think eventually we have to look forward to all those things. And touching, I don't know how you replace that. I'm reminded, and I looked at Judy, and Judy's father was an expert at this. I mean, he would just get next to the patient and pat him on the head, and they'd feel better immediately. I mean, it was almost like a faith healer. I'm sorry we have to lose that, but looks that way. We may, and I guess in the name of efficiency. But I hope we don't lose it completely. I'll have to say that.
Used to be a glass case when you went into the chest x-ray reading room at the Brigham, and it had a stethoscope in it. And the caption was, "Antique instrument formerly used for diagnosis of diseases of the chest." I guess this isn't the first time we've been through the alleged death of the stethoscope. Any hands in the auditorium?
Hi, you mentioned the objective measures that we could get for psychiatric evaluations using virtual medicine. And when it came to things like Holter monitors, evaluation of COPD, there were figures with this actual data. And I'm wondering if this was more of just a potential application or if there's published data of these objective measures already.
Oh, yeah, there's published data. I can't give you the numbers. I don't know what the numbers are, but I can tell you can look in the literature. There's published data on this, but it's early and it needs more numbers. There's no question about it, at least in my opinion. I think we need, more objective proof of the value of objective evidence as to what you can actually do with it. And then it has to have an outcome. In other words, okay, you know more about the patient, you know more about the patient's psyche. What good is it? Are you helping the patient with that? And you have to prove that. All those things haven't been done enough. There is literature on it. And I think you could, you could find it, but it's early.
Thank you.
Question online. COPD is a great example of how things clinically can change quickly. Due to a plug or spasm, deterioration at home can lead to death. In the hospital, can lead to intubation and that difficult course, but a life would be saved. I suppose the last sentence is, so telemedicine all sounds good, but risky. Can you please comment?
Well, let's see. Let's see about that, because, at least it seems that you can pick up things much earlier with all these monitors. And I mean, patients with COPD don't stay in the hospital for all their life. So it seems that if you do this, you can detect things fairly early. But there is a risk. I wouldn't minimize it. I think we have to see how it works out. I think your question is very appropriate, by the way. But I would answer it that, yes, that's a problem. But there are many reasons why these techniques can detect things early and are useful in that way. But that's something we have to watch. And then the results. So far, the results do not indicate an increased risk, but that could get lost amidst a lot of data. So we do have to look for those things. I would agree.
Can I ask you to expand on that for corollary risks? Anyone trying to hire a physician now quickly runs up. You cannot find a diagnostic radiologist willing to come to work in a hospital and read films. They want to read from home. And so the idea of let's walk over to radiology to talk to the radiologist seems to be disappearing from medicine. Similarly with some pathologists, I'll look at the slides at home, I'll look at digital files. What risks do you think this work from home for physicians pays through telemedicine technology?
Yeah, I mean, it could be, and God knows where they are. I mean, you could have the radiologist could be in Albania for all we know, or the pathologist. So it is, I don't know, is the question, what is the risk to that? Or
I'm asking you to speculate on the risks as increasingly providers don't want to set foot in the hospital or clinic,
Well,
and we never look face to face with our consultants or colleagues.
I think there is a risk to that, and I think there's part of the value of these consultations are understanding the patient clinically. And I think, we may lose a little of that in the way it's done. So I would agree with you. I think there is a risk there. But, we gain things, we lose. I mean, it's, I don't want to start with a cliche, but it's, progress, and we lose certain things. And I think we have to be, I would agree again, that we have to be very wary of what we might lose in these things, because there's always something, and we have to be careful about that. I agree. And again, I can, when I was an intern or resident, used to call them interns, I don't know. And when I was a resident and I used to go down and talk to the radiologist, I not only learned a lot, but the radiologist, he or she learned a lot about the patient and could, read the x-rays and whatnot more intelligently. We've kind of lost that. So that's a really good point.
Let's give the last word to this question here. I think that many people today are wary of remote surveillance and monitoring. Do you think there will be some reluctance on the part of patients to be monitored so robustly in the future, even if it's for your health? This reminds me, Dr. Kupersmith, of a cousin of mine who refuses to use Easy Pass on the New Jersey Turnpike or the bridges because she doesn't want, quote, the government to know where I'm going. Will Big Brother know what the pulse is in our foot or how many times we breathe because of this technology?
Well, again, I don't want to minimize those things, because there is certainly more than an element of truth that there's data is available on everybody, and somebody could look at it and use it. I mean, you can tell where a cell phone's been, who they're interacting with. I mean, you can do all kinds of things. So there will be, I think most people will accept these things as part of what we do now, but there will be people who are wary of it. And I'm glad, because I think there ought to be people who are wary and keep making those comments and objections to it. Not that we shouldn't do it, but that we have to think about those things as we do it and avoid the misuse in that way. I mean, we've seen so many examples of misuse of data on all kinds of things, not, more non-medical than medical, but medical as well. And so that's an issue. I would agree. I wouldn't. I use Easy Pass though, and I would agree, but not sure my behavior agrees.
The time has flown by. Thank you for a very stimulating session. Thank you for joining us.
Thank you. Thank you.